Welcome to part 2 of week 7, in which we are discussing cost of illness studies. And in this second part, we're going to look at some examples of cost of illness studies. The reason that I dedicated a week to cost of illness studies is I think that they are important, and they are jurisdictional. So the burden of disease changes from country to country. So they offer a good opportunity for doing some good studies in many parts of the world. And they are, I shouldn't say they are easy, but they can be completed in a short time frame. So if you're looking for a way to get into the field of economic evaluation, you might consider performing a cost of illness study if you have the data available, or if you are interested in the disease and you have the resources to collect the data. The first example is a cost of illness due to typhoid fever in Pemba, Zanzibar, East Africa. And typhoid is a bacterial infection due to Salmonella typhi, and it has a wide range of symptoms, but it has fever, abdominal pain. You can get constipation and headaches sometimes, and diarrhea. So some people actually call it enteric fever. And in this particular paper, the design was an incidence-based cost of illness study. So they identified a group of patients and followed them over the course of the illness. Now, for these ones, maybe some would have died, but first of all, it's a short course of illness. So you have a fever, which means that the course of illness is short. So they were able to do an incidence-based study, and they used a societal perspective, which means they included indirect costs, and they did micro-costing or bottom-up costing, as we saw in week 3. So they identified resources, measured the resources, and then valued the resources finally. And just to revise, identification means deciding what you want to include. Measuring means quantifying resource use. This is include. And then valuing means assigning unit costs. So here are the results of that particular study that we're using as an example. And this table is the patient characteristics of the cohort. And a very interesting thing I noticed reviewing this study was that they included 17 patients. So a very small number of patients. And they had 3 clinics, so 3 clinics here. And the median age was 19 years, in this clinic 33 years and 14 years. So relatively young patients, and the vast majority were females. So you can see 77 and 80%, although in this clinic only one was a female, so there were 2 males. And the number who were hospitalized were 40% here and 60% here. And all patients recovered, so 100% recovery rate. So no mortality in this small cohort. Then the results for resource use and costs. So this table was table 2, resource utilization and cost. And this is a continuation of the same table. So they had age, length of hospitalization was about 5 days. Then cost of hospitalization, they had a total of 1.29, and these are in dollars, US dollars. Although they have local currency units in brackets, so this is 1800 Tanzania shillings. But they had a treatment cost, a travel cost, and a meal cost. And then during this is before hospitalization. Then they had during hospitalization, treatment, travel, and food. Same thing after hospitalization, treatment, travel, and food. And then for total direct costs, they had treatment, travel, and food again. And then number of days of sickness before hospitalization, they had 12 days. This is a resource use estimate. And then total days of sickness, they had 21 on average, but more for children than adults. Then informal care, you remember that in week 3 we said informal care is a kind of indirect cost. And then they had a productivity loss estimate right here. And then total cost of illness is right here. So it's $154 on average, and it was 183 for children and 134 for adults over 15 years. So this was an example of an incidence-based cost of illness study. If you see in this slide, for the same study, they used the human capital approach, and in these two pictures, in these two parts of the picture, here they used the income of Zanzibar, which was the base case analysis. And you'll see that 83% of the costs were due to productivity loss. But when they did a sensitivity analysis and they used country income, average country income, Tanzania is composed of the mainland plus Zanzibar. So when they used the income of Tanzania as a whole, then the percentage of productivity loss went to about 58%. And this is likely, although I'm not sure, but it's likely because the income in Zanzibar, or the GDP of Zanzibar, is higher than the income for the whole country combined. So the authors also included an analysis by type of expenditure and time of expenditure, and you'll see that they were roughly similar. By type, nearly 13% was travel, and by time, again, it was about 11%. And for food, it was about 4, and here it's 5. And for total cost, it was about 84, and here it's 83. So they were relatively similar by type and time of expenditure. The next example is a cost of illness study using control methods, using a control group, and it's for epilepsy in a district in Burundi. And in this study, they had subjects who are epilepsy patients and general population controls. So this is an example of a matched cost of illness study. So they included direct medical costs and indirect costs, and they used GDP as a method for counting the indirect costs. And they did standard statistical analysis in their study. So if you look at the results, you see that the demographic characteristics suggest that the ages were roughly similar, and the sex distribution was similar as well. The gender distribution was similar, and there were differences by marital status. So the p-value here is close to 0.05. And you'll see that by employment, they also were similar. So the matching basically worked. I mean, this p-value is trending towards significance, but it's not significant. So there are no statistically significant differences between the patients with epilepsy and the controls. And that's what you want when you're doing a matched cost of illness study. And here are the results of the cost of illness. So you have epilepsy patients in this column and controls in this column, and you had more controls. Also a relatively small study. So you see that the epilepsy patients had higher costs, so $26.23, and these ones had about $14, and the difference was statistically significant. And you can see that there were differences also by consultations, by hospitalization, by treatment, and complementary examinations. But the controls had higher costs of complementary examinations. It was the only category in which the controls had higher costs. So this is what a table for the results of a cost of illness study based on a matched control group would look like. The next example is the costs attributable to AIDS at the household level in Chad, and it's a paper that was reported in October 2004. The methods used in this paper was that first of all, the patients were AIDS patients and not HIV patients, and it was in the time period before the widespread use of ARVs, or antiretroviral therapy, or ART, and it was a general population control group. They had patients with AIDS and a control group of patients who came from the general population, and they were matched on age, sex, profession, and residence. So it's another example of a matched control group cost of illness study. And they measured the 1 month cost extrapolated to the lifetime of patients. Now remember that at this time, without ARVs, HIV was a highly lethal disease, and this lifetime wouldn't have been a long time, it would have been a short time. They included medical care, lost income, and funeral expenses, pointing to the short lifetime I was talking about here. So here is the results table, and in the first table you see the average health-related expenditures of AIDS cases and controls, and then the difference, which is attributable to AIDS. So you'll see that for drugs and remedies, and this is in the 1 month prior to interview, because they were doing a community-based study, a community-based survey. And you'll see that drugs, there was an extra $43.7, and for fees for home consultation, an increase in $7.6, and so on. And you'll see that there would have been, for example, a $1.5 increase in hospitalization costs, and the total attributable cost for AIDS in the 1 month prior to the interview was about $80, $78.6. Only $4.3 was not attributable to the AIDS. And if you look at table 2 here, you see the average time lost for the principal income generating activity during the month prior to interview. You see that for AIDS cases, they lost a lot of time in days, 16 days compared to 2 days in the control, and the attributable number was nearly 14 days. And for other household members, presumably because they were taking care of the patients with AIDS, they were losing 8 days compared to nearly 0 days for the controls, and the difference is also around 8 days. So you have 24 total days and lost 24 total days lost for AIDS patients, and the difference is about 22 days. The next results table shows the lifetime extrapolation for the household costs of an AIDS patient, and they used an estimate of 6 months only from the time of the survey to death for AIDS patients, a very short time. And I talked about the shortness of people's expected life for AIDS before the advent of ARVs, and the miracle of ARVs, really, for those of us who practiced in the time in hospitals in Africa in the time before ARVs were widely available. So this is the monthly cost, about $80 for healthcare related expenditures and $40 for productivity losses. If you multiply by 6, you get $471 and $231. And then they did key informant interviews to calculate the average funeral expenditure, one-time cost, so $133 in funeral expenditures. And the total household cost attributable to HIV at the time was $836. So this is the total attributable household cost attributable to HIV. I wanted to present some of the other results in that paper, and I wanted to touch on the source of financing for healthcare expenditure. You will see that most of the money comes from household savings, right here, for both AIDS and controls, for both of them. And you'll see that people usually sell animals or agricultural products, but they also borrow. 9% for the AIDS borrow and 3% borrow. And this points to a point we made at the beginning of this course, which is that healthcare has a third dimension. In addition to increasing life expectancy and increasing quality of life, it has another dimension of financial risk protection. So if these patients were insured, they wouldn't have to borrow or sell assets to finance their health care. And this table 5 is monthly expenditures of households, and you see what people are spending on. So for patients who have AIDS, for households of patients who have AIDS, they're spending on things like food, but it's not different. Even those who don't have patients with AIDS were spending on food and clothes and stuff like that, and entertainment. And but the difference is that for the AIDS patients, they were spending a large amount on health, but the controls were spending not as much on health. And of course, the total expenditure was higher for those who had AIDS. So these are the kinds of tables that people present in cost of illness studies to try and understand what's happening and to really pinpoint the impact of a disease on the economics or on the burden of disease, the economic burden of a disease. The next example is the economic burden of malaria on households and the health system in Enugu State in southeast Nigeria. So this was a cross-sectional survey-based study. It estimated the outpatient and hospitalization costs, and they had direct medical costs, direct non-medical costs, which were just the transportation costs, and then they had indirect costs of lost income. So first of all, before we go into results, this was an example of the SAM diagnosis specific costs method, because they were interested only in the costs attributable to the malaria. So for outpatient, they had drugs, diagnostics, administration, and other fees, and then they had transportation and lost income, and they came up with an estimate of $12. And for hospitalization, they did the same thing. They had the same categories, and they came up with an estimate of $23. So that's all essentially that they estimated. So very simple, and like we said in the previous slide, cross-sectional study. And if you look at the categories, you see that besides the lost income, the productivity costs, the others are relatively small costs. So you have $9 here in lost income for outpatient and $12 here lost income for inpatient. So with that, let's end the second part of the 7th week of our course. And in the last part of this week, we are going to look a little bit in detail at a model-based approach to cost of illness. And this is a study in which I was involved, which was on the costs of induced abortion in Uganda. So thank you very much, and I'll see you in part 3 of week 7.